Hello, and welcome to the Innovation Forum AI podcast, a space where we explore how artificial intelligence is transforming public health. My name is Oliver Morgan, and today I'm talking with Zainab Samad, a cardiologist and outcomes researcher at the Aga Khan University in Karachi, Pakistan. Zainab's work advances AI-driven insights and gender-inclusive research to strengthen health systems in low and middle-income countries. Welcome, Zainab, to the podcast.
Thank you, Oliver, for having me.
It's great. I feel like I saw you quite recently because we met at the World Health Summit in Berlin a few weeks ago. And actually then before that, it's an event that we had here in Berlin. So it's great to catch up with you yet again in person online.
Thank you. It was actually a lot of fun visiting Berlin at the World Health Summit, as well as really learn about all the great work that's happening at the WHO hub.
Great, thanks, Zainab. Well, maybe we can get started by hearing a little bit about your background and your kind of career journey and how you've gone from cardiology to AI.
So, Oliver, I think about our careers as these, actually, they're almost stories that evolve over time based and formed by our experiences in life, right? I'd say that, when I was a medical student a very long time ago here at the Aga Khan University, I actually was, I remember this very one distinct case where I was taking care of a young woman with rheumatic heart disease. And she had just gotten her mitral valve replaced with a metallic valve, and her surgery had gone well. And she was discharged from the hospital. And about a month later, this is in a hospital in rural Punjab, she had presented to our hospital with a stroke, a dense hemiplegia. And I felt so terrible because what I understood at that point with that case was that that woman, that she had received the treatment as was prescribed by the textbooks, but the systems around her had failed. She did not have access to warfarin clinics. She could not maintain her INR. And so she had thrombosed her valve and sent a clot off to her brain, And so it was at that point where I realized that it's not just treating a patient, but really thinking about the systems that support the development of disease and how outcomes are different for different people because the system fails them. And so that was then solidified by a lot of work that our medical school makes sure we do as part of our community health sciences rotations. We rotate through low-income neighborhoods in areas of Karachi. And that's where I realized that we had a ton of preventable disease and population after population, and that we really had to work upstream for a treatment, working on prevention. That's where most resource allocation, at least in a country like Pakistan, had to be spent. And then when I went to Duke for my training, that's where I really learned the methodological rigor, how to actually question, make a research question. When we would take care of our patients, every single time, without fail, the question would be that we'd get challenged with was, what's the evidence behind your decision? And so we had to bring the data to the table, and we had to bring the evidence to the table. And the evidence didn't exist, then we were encouraged to, generate the evidence. And so in that period of my life, I really learned how to actually use data to inform the decisions we make for our patients. And so all of those experiences, the multiple layers of it, how to be an empathetic clinician, seeing the systemic failures, the systemic barriers that our patients face at the population level, even at the institutional level, how we can use data to circumvent those barriers and inform their care. So that's, I'd say that those are the kinds of experiences that have shaped who I am and, the work that I've done so far.
Well, thanks so much, Zainab. One of the pieces of work actually that has really stood out that you've led on is actually looking at the gender differences in myocardial infarction in Pakistan and using AI to understand some of those differences. Maybe you could just talk a little bit about that, because I think that's just such an exciting example of how clinicians can apply AI in the real world setting.
So, Oliver, that's one of the works that came out of another set of endeavors that we'd taken. We actually wanted to organize and curate our information at the Aga Khan University Health System. And while we were doing that, we picked up acute myocardial infarctions because we want to understand how they're done in our system over time. And what we found with a very lean digital data set was that mortality had actually gone down over time, even though we were getting more complex patients. But at the same time, what we found was that women with ST elevation MI were doing far worse than men. And so this was one of those facts that comes out, and it's a what, and you need to understand and unpack it, understand why that's happening. And so we've done this work on something like 14,000 individuals, and it would have been almost impossible task to go back 30 years, pull the chart summaries, because we have a hybrid electronic medical system. We have paper chart as well as electronic systems. And so at that point, AI came to our rescue, where we developed a natural language processing tool that we then applied to the discharge summaries that we had available on patients to understand, what were the symptoms with which people were coming in with acute MI. And at that point, we realized that women were actually coming in with a fairly they were coming with chest pain, but they were also coming with additional symptoms that wouldn't necessarily make a clinician put them in the acute MI bucket. And that, I think, was a very big insight for us, because it made us think about the fact that those symptoms not fitting the classic presentations were not only hindering patients in their own risk assessment, do I need to go to the doctor, am I having a heart attack, but also hindering the clinicians that were seeing them at the front line, and figuring out how to actually best diagnose the symptom complex that they were seeing. So I think that actually the tool really helped us uncover an important inequity, but also diagnose why that existed as well.
Yeah, that's a really great example of how you can use AI to leverage the data that you already have. Even if it's not in digital form, you can use AI to help get it into a digital form and analyze it in a way. How have the clinicians reacted to some of the use of AI in the clinical setting? I know that some are maybe a bit reticent or a bit worried about AI resulting in a lack of empathy in decision making. Has that been your experience?
Well, I think clinicians, because they are already overburdened so much with documentation, you become a clinician because you really care about problem solving. And there's this whole empathy piece where a lot of us who are clinicians are driven to this career. And all that we end up doing, a lot of our time is taken away from that really important human connection to administrative and documentation tasks. And now we are getting AI that can do ambient listening, that can help with documentation, that can do the calculation of risk stratify for us, and actually, free up our time then to be really able to concentrate, make time for the patient, focus on the conversations that are important, helping the patient understand their disease better, and helping them make their decisions around their treatment care plans. And so I think the way I look at AI, I really believe it will help create the greatest gift that it can give us is allowing us to actually focus and free up our time for the patient and allowing us to hear the patient.
Well, you've certainly taken that piece of work and expanded it. I know you set up the Health Data Science Center at the Aga Khan University in Pakistan, and been looking at the burden of disease in other areas as well. How has this work been evolving since your, I guess, initial work on myocardial infarction?
So after we worked on MIs, we realized that there were insights that we could draw on multiple other conditions. So we knew first, we kind of developed the playbook of how to organize and curate the data. What are the methods that we should be using? So we find that in our systems, we will call the same thing 5 different things. But how do you group those conditions as one? How do you standardize and use data models that are speaking the same language as another system? So those are all the things that we learned. And we didn't pick up, we picked up acute MI, we learned from it, and then we transferred that learning to several other conditions. So for example, at our department level, I'll begin with the department level, we actually pulled out information on multiple different disease states for which we know quality improvement pathways exist. So we were able to extract those and actually make very simple dashboards to show what the mortality for different disease conditions was. And then that would allow us to benchmark against other hospitals to see how well we were doing and what we could do better to actually improve our own outcomes. And then from there, we took the case and we delved into um, our lab network that exists across the country, which offers almost like a liquid biopsy of Pakistan, right? So we picked up, being a cardiologist, I'm going to pick up something that's related to the field. We picked up lipid profiles. And we looked at lipid profiles to see what did they look like across the country. And we found that, familial hypercholesterolemia, or LDL greater than 190 milligrams per deciliter, was almost in 135 to 1 in 40 labs ordered. And this was such an important revelation because, this is one of the reasons why we're probably seeing acute MIs very early in our country. And that then we went and took that information to our ministry to kind of keep them in the loop. This is where I think we would translate what we learn at the health system level to the policymakers and decision makers, because they could do so many things about awareness, creating subsidies for labs, and creating policy around screening for some of these conditions. So those are some examples from within our health system. But we also realized that the health system can't just speak to every problem that's happening in Pakistan, and we really needed to collaborate with several other institutions in terms of collating data. I'll give you another example. We, as frontline clinicians, we knew dengue is a problem. Okay, but this fragmented underreporting of data that's happening, and so it's not being highlighted in the national state as a real issue that is a big issue in Pakistan. And so what we did was we created a collaborative of our institution with several other institutions that had lab networks, and we aggregated data. And while we did that, we realized that the dengue burden was actually multiple folds bigger than what had been reported for our country. And while we did that, we not only created a collaborative network of individuals who learned to trust each other, who learned how to kind of standardize methods, how to pull information from their own institutions, but we also were able to develop the process. And the process of making that collaborative network is actually an additional product apart from the insight that we got about a specific disease condition like dengue. So this has kind of been a bit of like a journey, expanding from our own institution, but to other institutions across the country.
And how have you found that the policymakers have responded to the use of AI in this type of this work that you've been doing? Were they skeptical? Were they enthusiastic? Do they see new possibilities going forwards? How have they reacted?
So I think the policymakers in Pakistan, they at least the ones we've interacted with, have been very forthcoming. They have been not only very receptive to the insights that we draw, partly because we do a good job of kind of meeting them, keeping them in the loop, and kind of telling them about all the latest methods that we're using. But also, I think for how AI might be beneficial to the government itself in implementing programs, in prioritizing programs. I think they've been pretty receptive and open to the use of AI. Embrace it as an upcoming technology that can really help us leapfrog in terms of improving outcomes for our population.
Yeah, I mean, how do you think this will or could play out in other countries like Pakistan, which maybe has a fragmented health system, or, as you said, a blend of both digital and paper systems? Do you see that this is, as you said, an opportunity for low and middle income countries to leapfrog from the kind of progression from a purely paper-based to a digital-based information system that can drive policy?
Yes, I think, Oliver, I think there are a couple of pieces to this. I feel like AI can create or add value in multiple different ways. You see, just not only in the way like to think about the system as the user of the health system and the health system itself. That involves not only clinicians, nurses, other healthcare professionals, and even the policymakers are part of the health system, right? I think in terms of the users, AI is already changing the way they interact with their disease and how they get health information. So we have patients who are coming into clinic who've looked up what their disease and the symptom complexes might be representing, and so they're very early adopters. So in that way, the health system should be ready, and I think that's where one place where AI can help. It can help beat out misinformation. It can help improve health literacy on the user perspective. And then in terms of the health system, I feel like there are so many areas that are far flung where the internet can reach, but perhaps a car may not. How can we improve disease detection and disease management in far-flung areas with the help of AI and telemedicine? How can we improve on the just-in-time knowledge access for clinicians all over the country with open source AI tools? And so I think I believe that there is a lot of um, scope and opportunity, especially in LMICs like Pakistan, where if we looked at the user and at different levels of the health system, how AI can be integrated. I do want to point out that I think for AI, it is important, especially in systems that are not completely digital, right? How can we get it onto the devices? Because not everybody might have a laptop or a fully integrated electronic medical record system, but most people will have a device with them. So, how can we kind of even leapfrog that technological barrier to get to the users as well as the implementers of the health system?
Yeah, I know that you've also been collaborating a lot with different entities in different countries and championing a lot of South-South collaborations across Africa, South Asia, also across the Middle East as well. I mean, how have you found that some of these barriers and challenges have been overcome, or are they not being overcome?
So I think in terms of our South-South collaborations, when I'm actually speaking with a colleague in Kenya, or I'm speaking with even another colleague in a different institution within Pakistan, we've got a very shared reality of what we're dealing with on the ground, right? We know what the barriers are, what the challenges are of a hybrid paper digital system. We know the barriers of internet outages, electricity outages, roadblocks, and we know how to navigate these challenges. So I think there, just like I pointed out, in another world, we could have been able to extract every piece of information we could because it would have been digitally available across a 30-year period in a different country. But we didn't have that. But yet, what we did, we were nimble about using an AI tool to circumvent what we didn't have in terms of information. I gave you the example of the NLP tool. Another example I can give you is we were looking at people who are being admitted to the hospital, and we were looking at our in-hospital mortality. And we realized, Oliver, that about almost half of that mortality was occurring in the first few days of admission. And that's something that was a challenge, and we needed to figure out how best to flag these high-risk patients so that the clinical teams are aware and they can quickly do everything to save the patient's life and in fact have those early conversations with the patient and their families. And so we went and decided to look at how could we create a machine learning algorithm. And I'll tell you, the data that's captured in our systems is lean, but we were able to build an AI algorithm using just the information that we had, and it was pretty accurate. So I think in South-South collaborations, we are able to do transfer learning around things like this. You can create the model for your specific problem using the data that only you have, that is not maybe very comprehensive, but it will be able to accurately predict outcomes for your patients or any other specific tool that you're developing the model for. So I think that's one area that I think can really be transferred from one country to another.
Yeah, it sounds like there's a lot of potential for South-South collaborations in the kind of clinical AI space. Maybe that might be more effective than the North-South collaborations, where maybe some of the technologies in higher income countries are more data rich and have different approaches using AI. Is that a reasonable summary?
I think in South-South, you've got that shared reality. You know exactly what challenge someone else is having in terms of data, what they're dealing with. But I think there is great value to North-South collaborations as well. And I'll say that in that the some algorithms may be developed on extremely rich data information. So, for example, the availability of vital signs every 15 minutes or continuously on some patients, and we may not have that resource available to us. But what can be transferred in a North South collaboration is the process. How do you do this in the best possible way? How do you make sure that the data pipelines are built? They're clean, the data is compliant, it is conforming, and there is actually the quality is high. And so that process transfer can happen between North South, even if the data infrastructure environments are not the same.
Well, that's super interesting. I mean, thinking about some of the kind of broader ecosystem also in countries, I know that one of your multiple hats is that you also sit on Pakistan's National AI Policy Committee and also help with Pakistan's development of its AI policy in the healthcare space. What has that process been like? And looking at it from a governance perspective, what are some of the challenges that you've had to overcome?
So, I'm actually really glad that Pakistan has developed its, first national AI policy. And that meant that, the government has decided that this is something that they are heavily invested in, that they're futuristic in their approach, and making sure that this technology can benefit everybody in Pakistan. So the things that we advocated for when the policy was being developed was one, that it should be inclusive. It should really be equitable in approach, not only when you're training people and health professionals, that it should uncover inequities and help us actually address them. And then we advocated for the fact that the policy should address AI not for the sake of AI, but AI for the sake of understanding our problems and addressing problems that are actually in Pakistan. And so that's the big kind of pieces that we brought to the table. Also, our team had a fair amount of experience with, again, data. How do you digitize and standardize information? We had a lot of experience with actually building our own local models. And so those are some of the use case experiences that we brought to the committee. Health sector is one area that will be transformed with AI. And how do we go about doing that using our own local talent and resources? Those were areas that we, brought to the discussions at the policy forum.
Well, that's super interesting to hear. I mean, is there a regulatory process yet in Pakistan for the use of AI in health and public health?
So they are developing that at this point. So the policy document was the first of a series of documents that are going to come out. And so there is at multiple different institutional levels, whether it's at national research institutions, or at the ministry level, they're working on data governance frameworks. And so it'll be a series of documents that we'll see coming out. I think this was the one that they kickstarted the whole process with.
Yeah, I think many countries are on this same journey as well of trying to understand how to regulate the use of AI in healthcare and public health. Uh, are you also exploring in the public health domain how to use AI in the surveillance setting and also detecting outbreaks and potential risks of epidemics in Pakistan?
So we've done some very initial work, Oliver, in this space. We picked up dengue as our use case again, because one, we'd mapped the burden of dengue across the country, but also to predict when we're going to see the next phase. We don't have vaccinations in the country. We do not have other means like, Wolbachia infected mosquitoes. But what we do have is a population that can get pretty aware and try and control vectors. And so that's one space that we worked in. We're trying to bring the collaboration such that the collaborative network that we leverage for burden of disease estimation is then able to put information to pipeline where we can predict the next outbreak. And here we're also collaborating with the National Institutes of Health, the integrated disease surveillance and response system, because they've got a pretty robust pipeline of information that they get from multiple public sector clinical centers. And so they would actually be the one really serving as a backbone for the information, but also in terms of policy and implementation response, they would be leading some of this work.
So is your AI center based in an academic setting, right? It's in the university, but you're also working across different government entities as well. Presumably, that's the way that many countries will also have to, I guess, tackle some of the AI challenges ahead. Using both the academic sector as well as the public sector to use this in real life.
Yes, Oliver, I think the way this is like, our team is very multidisciplinary. I've talked to you before about the fact that we not only have clinicians, but public health practitioners and computer scientists and folks who've got experience with management and health policy. But the same multidisciplinarity that's required for health data science, we will have to develop across institutions. Different institutions bring different strengths. And I think in a collaborative, even if it's at a country level, if somebody says, okay, I've got the best modeling team, then they bring the best modeling team. If another person says, okay, we're going to provide the data infrastructure, another provides the security, and another provides the regulatory cover that you require for some of these investigations, then I think that's a win-win situation. And that's the kind of situation and win-win scenario that would be beneficial for a longer future vision for pandemic preparedness. If we were to do this at a multiple country level, the same kind of framework could be useful, where different countries can bring in different kinds of resources that are shared then across not only institutions but countries as well.
So it sounds really like the AI opportunity actually is the opportunity to maybe create new collaborations and work together in a different way above and beyond the technology itself. Maybe it's just injecting a level of interest and excitement that re-energizes this space. Is that right?
Yes, I think so, Oliver. I realize that, in a crisis, that's not the moment to develop a collaborative network. That moment of crisis means that you already have a network of people who worked in a non-crisis situation together. They've developed the collaborative muscle. They've developed the trust muscle between each other. They are on a first name basis, and they have learned how to navigate their each individual, institutional, country level challenges for working on projects. So if a crisis, and when it ever hits, you've got a network that is in a ready, set, go fashion, that you aren't sitting at that point and sending out introductory emails and signing MOU negotiations, but rather you've got a network that's ready to go, and can push out a country level or multi-country level analysis, not in a matter of months but in a matter of few days. So I believe it really is that the technology is there to help us. It is the human connection which will get us to to that outcome that we wish to see in any future scenario.
Well, maybe just kind of wrapping up, focusing on the human connection, like bringing it down to earth. I mean, what would you advise for listeners to this podcast who might not know too much about AI and who might either be working in a clinical setting or in a public health setting and would like to get more engaged? Is there something that you've learned in your journey that might be helpful for them?
So the first I would say is that you've got to be passionate about a problem that you want to solve. And that problem is what actually helps people put their egos aside and come and drop the institutional silos and the institutional walls and come together across departments, across institutions. So I think if anyone is interested in a particular problem and they've identified who are the people working in that space, now is a good time to reach out to them and figure out how they can get involved and engaged. And over time, it's actually, I think, human relationships, the social infrastructure, the relational infrastructure, that's the investment that we need to tackle any big crisis down the line.
Great. Well, that's been so inspirational and exciting. Where can people find maybe more information about some of the projects that you've been working on or the center that you run?
So, Oliver, we actually have a page on our the Aga Khan University's Medical College website. If you can Google Health Data Science Center and the Aga Khan University Medical College, it should be able to pop up as the first few set of hits. And then I have an email address. It's samad.zainab@aku.edu. And we also have a data.science@aku.edu email address that people can reach out to us on.
Great. Thanks so much, Zainab. And we'll be sure to put the links also in the show notes for this episode as well so that people can find them easily. Thank you so much for taking the time to talk with us. It's been really great talking with you just today, but also getting to know you and the work that your center has been doing over the last few months. And I look forward to working together in the future.
Thank you very much, Oliver, for having me and this conversation. Thank you.
Thanks so much for joining us for this episode. We hope you enjoyed it as much as we enjoyed making it. Be sure to subscribe and share this podcast with your friends and colleagues. We'll see you next time.
The Innovation Forum AI podcast is produced by Zoila Leiva Rioja and brought to you by the WHO Hub for Pandemic and Epidemic Intelligence. We'd love to hear your feedback and ideas. Reach us at pandemichub@who.int.